Okay, we are back. This is Senate Health and Welfare Committee meeting, January 20th, and we're continuing today looking through some of the bills that are in our committee, and we have with us the Honorable Senator Randy Brock. Thank you for being here, Senator.
Thank you very much.
It's good to see you. And why don't you not walk us through, but give us an overview of S206 and your motivation for sponsoring it. And we look forward to hearing your testimony.
Great. Well, thank you. This bill is probably not new to this committee. It was introduced originally in, I think it was 2019, 2020, and unfortunately it didn't get acted on at that time, and so it's back again. The background is this is a bill that is about Alzheimer's disease and dementia. And I think it's probably useful to kind of put this into perspective a little bit. We have in Vermont right now about 13,000 people who suffer from Alzheimer's disease and related disorders. And that's estimated to go up to about 17,000 folks, a 30.8% increase by 2025. That's a lot of people. And Alzheimer's disease, for those that aren't intimately familiar with, is one of those diseases in the top 6 or 7 killers that has no cure. A person who has Alzheimer's disease will die of that disease if something else doesn't kill them first. And it is a disease that is inevitably fatal. It's a disease that consumes an enormous amount of resources in Vermont. About 17%, according to a statistic that I just found here, of people in hospice have a primary diagnosis of Alzheimer's disease. We spend about $116 million a year of Medicaid funds dealing with caring for people who have Alzheimer's disease. And the Medicare expense is about $23,800 a year, again, for Alzheimer's disease in Vermont. Beyond the people
are you saying $23,800 per
and
person?
$30 per capita.
Per capita, yeah. I was going to say, wow, that's not much, but I got it. Thank you.
Thank you. We have, though, it's a disease that doesn't affect just the people who have it. It affects their caregivers. And there are about 25,000 Vermonters who are caregivers of people with Alzheimer's disease. And when you think about the amount of value, of cost that represents, of people who can't work, who can't do anything else, whose time is consumed with delivering care, because so often people don't have long-term care insurance, although that certainly would be something I think that everybody should be recommending to the extent that people can afford it. And people essentially spend down all of their savings time and time again in order to be eligible for Medicare costs for Alzheimer's care. Now, that being said, we have in Vermont an Alzheimer's and related disorders commission. And on that commission, a number of folks from a variety of disciplines and ranging from hospitals to doctors to long-term care facilities. And there are 2 representatives of the legislature, one Representative Dan Noyes from the House and myself from the Senate who serve on that commission. And this particular bill is a bill that is sponsored by and promoted by the Alzheimer's Commission. It's based to a great extent on a bill that was passed several years ago in Massachusetts. And there's a lot of literature as a result of that bill in terms of it achieving some positive success. This bill isn't asking for any money at this time, which is probably miraculous given the amount of money that we really need for Alzheimer's care. And I would add before going, it's also something that to me is very personal. I have a father who died of Alzheimer's disease after suffering from that disease openly for 8, 9, 10 years. And my wife's mother also died of Alzheimer's disease. So it's a disease that affects all kinds of people and certainly throughout our state. This particular bill, part of it, as we walk through the bill itself, there is a preamble that talks about what it does. It creates an assessment, a requirement to create an assessment and a state plan. And by the way, we have a state plan underway right now. We got some funding from the CDC in 2020. We got a 3-year Building Our Largest Dementia BOLD grant an infrastructure grant in order to create a state plan. The last time we had a state plan was in 2009, and it was a plan that unfortunately I think largely sat on the shelf and didn't really move us forward the way that we want to do. And what this bill does is it does create a mandate and a requirement to produce a state plan and to do it on a regular basis in order to get a plan that's actionable. Senator Lyons, did you have a question?
No, you answered it. I forgot it was in the bill and I'm not looking at the bill. Go right ahead.
So if I can, I could go through the bill pretty quickly. It's pretty short. It's not tremendously complicated. The Section 1 of the bill creates the requirement for the Alzheimer's Disease and Related Disorders Commission to produce and carry out an assessment of state programs that address Alzheimer's disease and create and maintain an integrated state plan to respond to it. That plan and the purposes of the plan are to increase the development of treatments, help coordinate healthcare and treatment of individuals, ensure that the plan is in fact equitable to all populations of the state, coordinate with federal entities to integrate and provide some information and coordination about Alzheimer's disease research and services across the state, and provide a strategy to increase the diagnostic rate. That has been a problem, by the way, and that all physicians don't seem to be up on the latest diagnostic techniques and so you have an awful lot of people who have the disease and there are long delays in diagnosing them with it, and that has an impact on their treatment and on their care. Section 2 of the bill provides some continuing education assessment, and the Alzheimer's Commission is charged with creating a work group to make recommendations on continuing education requirements for the diagnosis, treatment, and care of patients. And the work group will coordinate with the Vermont Medical Society, the Vermont Association of Hospitals and Healthcare Systems, and other professional groups in doing that, and then submit its findings to both the full committee and then approval of the commission, and then upon approval of that, then to the committees such as yours that are responsible for healthcare in the General Assembly for action on its recommendations. The third section relates to diagnosis of treatment. We hear and have heard repeatedly of cases where people go to the doctor and sort of get diagnosed with a cognitive impairment, but their family members don't really know about it, and it goes on and doesn't get resolved. And what this does, it simply says, to the extent permitted by federal law, a physician licensed upon express or complied consent of a patient diagnosed with Alzheimer's, report the diagnosis to a family member of the patient or agent as defined, and provide the family member or agent information about care planning and services. Understanding from a family member of what that diagnosis means and what they could do about it and where they could go for help is critical to prevent folks from falling through the crack. And the last piece of the bill is it requires a hospital operations plan, saying that a hospital shall at least have a plan for the recognition and management of people with Alzheimer's, dementia, or delirium in acute care settings. Most of our hospitals have that, but unfortunately some do not. And so what this does is it asks them to do it. Now, there is a typo in the bill that I should point out. It says on the third to the last line that plan shall be completed by January 1, 2022. It was not my intent to put a mandate in that it's required to be completed before the bill was introduced. So we do want to correct that.
Oh, but we work so fast in this committee. We can go backwards.
That's the proposed bill in a nutshell. There are folks from the Alzheimer's Association and supporting organizations that are prepared to come in and provide testimony that can go into much more detail and competent discussion than I can.
Thank you, Senator Brock. That was extremely thorough. And we will go through the bill again with Ledge Counsel, and we'll find that typo. and we'll complain about it, but not
That's
really.
my fault, not theirs.
No, it's not. And, I know that you and I talked about this bill back in 2019, and then COVID came and destroyed those good plans. So we look forward to taking the bill up. We will more than likely take the bill up and work on it. So yeah, appreciate the time they've taken. Questions. I do have one question before I open it up, and that is, can you please send contact information? I know some of the folks in the Alzheimer's group, but it would be helpful for you to send contact information and names that you think would be important to informing us about the bill. And you can send those to Aaron. You can copy me, fine.
Okay.
That would be great. Yeah, and then that'll save us some time moving forward. Senator Cummings has a question.
No, I think you probably know, I worked in an adult day. I did the outreach, I did the home visiting, and I am very concerned. We didn't have enough adult days, and the ones we had were struggling financially. We have lost 2 due to COVID.
Mhm.
And one of the ways we would frequently find new participants was that their caregiver would end up in the hospital with exhaustion. These were frequently men who were going to take care of their wife on their own. It's an exhausting disease. They don't sleep at night. They pace. They can turn violent. Perfectly nice. We had a lovely, tiny, little, about 4 foot tall woman with a bad back, and she came in for a visit, and I came out, and she'd nailed our 5'7" or 8" EMT to the wall, taken out 3 people, and left. It turns out the police knew her well from escaping. She had her husband terrorized. We need a plan, but this is a present crisis, and COVID has only made it worse. Respite is key to anyone dealing with anyone who, oops, that's my phone call. But I'd love to decorate this. I'm going to resist
Senator,
I got to go talk about cannabis.
Right. You've raised some issues that we certainly can consider, and hopefully Senator Brock won't object to any improvements we put in the bill.
Not at all. And I think Senator Cummings are right on the mark. It's not only that Alzheimer's disease kills people, it kills their caregivers too.
Right. We don't need that. Senator Hardy.
Thank you, Senator Lyons. I just wanted to thank Senator Brock for bringing this bill forward and inviting me to co-sponsor with him. This is a disease that I think all of us have experience with in one way or the other, directly or indirectly. And certainly we all have constituents that do. So I'm glad that we're taking this up, and just I'm sure we can decorate the bill, but I also want to make sure that we get it over the finish line so that we can certainly start to do the important work that Senator Brock laid out. So thank you for your work on this.
Thank you.
Okay, and you are on the Alzheimer's Commission, and I know you've been very dedicated to that. And I think you probably know Daniel Bean, who,
Sure.
Yeah, he and I were colleagues for many years.
Yeah, no one will.
And and he had a family member with Alzheimer's, and that was a very sad. Very sad. Any other questions for Senator Brock before we move back to Ledge Council and go through the bill? Okay, you are welcome to stay and listen.
Well, unfortunately, I would love to, but unfortunately, I've had to escape from economic development to get here, and I think they're pulling me back.
Okay, well, do well in economic development. Take care of our remote worker program, please. Okay, Katie, Senator Brock did a great job and he did walk through the bill, but let's walk through again, and maybe there are some things that obviously there'll be people we want to hear from, but let's just go through the bill and see what's what.
Sure, let me pull up the document. Okay, scroll back up to the top. So this is S206, and as you said, Senator Brock already did a pretty thorough job walking through it, but I'll try to highlight the different sections he was referring to. So in section 1, this is our assessment and state plan piece that he was referencing. So as you know, there's already an existing commission on Alzheimer's disease and related activities. And this directs the commission to develop and carry out an assessment of all state programs that address Alzheimer's disease. The commission is to create and maintain an integrated state plan to overcome Alzheimer's disease, which is to include implementation steps and recommendations for priority actions based on the assessment. And there are a few listed purposes of the plan, including accelerating the development of treatments that would prevent, halt, or reverse the course of Alzheimer's disease, helping coordinate the healthcare and treatment of individuals with Alzheimer's disease, ensuring inclusion of ethnic and racial populations who have a higher risk for Alzheimer's disease or are least likely to receive care in clinical research and service settings, with the purpose of decreasing health disparities in Alzheimer's disease.
That's a really long sentence.
It was a few tongue twisters in there.
Yeah.
Coordinating the federal government entities to integrate and inform the fight against Alzheimer's disease. Providing information and coordination of Alzheimer's disease research and services across all state agencies. And then the last purpose is implementing a strategy to increase the diagnostic rate of Alzheimer's disease in the state. So that's the plan. And then subsection B says that by January 1st of 2024, the commission is to submit its assessment and state plan to the governor, the House committees on healthcare and human services, and this committee. I will note that this, this was a 2022. I was thinking this is a 2021 bill. So the dates have been updated. Okay, next section is the continuing education. So this directs the chair of the existing commission to appoint 3 members of the commission to form a work group for the purpose of making recommendations on continuing education requirements related to the diagnosis, treatment, and care of patients with cognitive impairments, including Alzheimer's disease and dementia. And this small group is to consider continuing education requirements for physicians, physician assistants, advanced practice registered nurses, and licensed practical nurses and nursing assistants, and appropriate training for adult protective services caseworkers. And in the course of developing these recommendations, the small group is to consult with the Vermont Medical Society, VAS, and other professional groups relevant to the professions that are specified in the subsection.
Maybe we should identify specifically I forget the exact name, but the Nurses Association as well, because the nurses are specified in there. And then we could put other professional groups after that.
Okay.
Oh, that's just a suggestion. We can talk about that. And when the Alzheimer's folks come in who've helped draft this, we can ask that question.
In terms of process, with these recommendations, a small group is to submit its findings and recommendations to the full group by November 1st of this coming year. And then upon approval of the full group, the full commission, the findings and recommendations would be submitted to this committee and to Healthcare and Human Services by December 1st.
So, and you don't have to move back, but in the plan itself, I'm thinking about Senator Cummings' comments, and I wholeheartedly agree with her about an assessment. There is an assessment in there of facilities, but of the needs for caregivers, at-home caregivers, or the respite issue. Just to pin that and just remember that maybe we can come back to that.
Write that down. Okay. next section has to do with providing information to the family or agent of a patient with Alzheimer's disease. So to the extent permitted under federal law, a physician licensed in this state, upon express or implied consent of a patient diagnosed with Alzheimer's disease, shall report the diagnosis to a family member of the patient or an agent of the patient, and provide the family member or agent information about care planning services, including assistance understanding the diagnosis, medical and non-medical options for treatment, services and supports, and information regarding how to obtain treatment services and supports.
This might be an area for discussion too. I'm just trying to figure out how to get that consent. We talk a lot about consent forms. We also had advanced directives and things that would maybe help in this section, but I don't know what our answer will be at this point.
Okay, and then the last substantive section is the hospital operation plan. So this directs any hospital licensed to implement an operational plan for the recognition and management of patients with dementia or delirium in acute care settings. And this operational plan is to consider applicable recommendations made by the commission. And here is the language that Representative Brock was mentioning. So Senator, I'm sorry.
Okay.
Oh, I apologize.
No, it's okay. We all do it.
Each hospital's operational plan is to be completed on or before January 1, 2022. So we would update that to be 2023 and remain on file at the hospital and made available to the Department of Health upon request.
Is there anywhere else we'll have to talk to Department of Health, but there is a reporting process for Alzheimer's. Is that a reportable disease? Trying to remember.
I'm not sure. I'd have to check the list.
Yeah, it's a long list. So we just want to figure out what this does for the in terms of the Department of Health and what they do with that once they have it. I mean, are there any requirements for follow-up to see if it's being followed? Who knows? Okay. Look at that. All right. Senator Hardy, go ahead.
Sure. Just wanted to flag action is that one, even with changing the date, so it's not traveling back in time, just want to make sure that hospitals, given everything that they're dealing with right now, could do this in that time.
Yeah, that's a good question.
They're a little swamped.
Yeah.
So we should
Yeah.
hear from them, obviously. Then also just wondering, if we might want to ask long-term care facilities to do a similar plan because, or nursing homes, because they're often the places where people with Alzheimer's are. They may be in the hospital, but then are more, or home health agencies who are, I don't know, just, I'm looking forward to testimony to learning more about it, but just wanted to.
Yeah, that's exactly the way I'm feeling. The issue around long-term care facilities, we can invite Jill Olson in perhaps to speak to that and or others. And I don't know to what extent we want to push the planning out, because I'm thinking about, if you're thinking about hospitals and the burden that they're under, long-term care facilities are also swamped right now. So we'll just have to play it by ear with that. And I mean that literally, listening to testimony and then sorting out what we can do and what we can't do. Okay. Any other comments or questions for Katie? Senator Hooker.
Thank you. Just a question back in the purpose. It states that it's a plan to overcome Alzheimer's disease, and I'm just kind of wondering what the term overcome would mean. I hope we can overcome Alzheimer's disease. I just don't know if,
yeah, it's a good question. I mean, he did talk a bit about the testing and the research, the diagnosis and the reporting. So overcoming what? barriers or lack of information around Alzheimer's. Things have changed radically over time about the diagnosis and treatment. And now we're seeing all the ads on TV and the internet about all the new products that prevent and slow down. So, oh well, you've asked a great question.
And they're very expensive.
Yes, they are.
They are blowing Social Security increases.
Are they really?
Yeah, it's had an impact on Medicare because it's like $2,800 a dose or something. It's very expensive.
A daily dose?
Probably.
Yeah. Well, no, it reminds me of the MS drugs that went up to $34,000 a year. So this would
Yeah.
be more than that. Wow. Okay,
Yeah.
well, we have a lot to learn. So is there anyone who doesn't think we should go forward with this bill? As I look at it right now, and as Senator Brock suggested, and Katie, you can correct me if I'm wrong, there doesn't appear to be any fiscal implication. So
You're asking an existing group to work on a
do
specific
something.
topic. So I think a lot of the appropriation would be folded into, it's not a new appropriation, it's folded into the amount
Right.
you already appropriate for that group.
So that's good. Maybe we can do something policy wise and help to move this forward. So we have a bunch of folks to invite in. Let me know who you think you'd like to hear from. We may have to do some triage, but certainly the Alzheimer's Commission will want to hear from long-term care folks maybe. And I'm thinking that they've listed some. Katie, is it usual to list specific organizations? I noticed VMS is Vermont Medical Society is listed. Do we usually do that, or do we say stakeholders?
So I think the way it's phrased,
Interesting.
and let me look at it, directs a state entity to consult with them. I think it would be unusual to direct
Okay,
VMS, for example, to consult with somebody, but I
Got
think
it.
the reverse is happening here.
okay. And then the other question is, and maybe I should catch up with Senator Brock on this. I'll bump into him in the hallway. The question about the gerontology clinic or work that's being done at the University of Vermont. I know that we used to have a very robust program on gerontological research, including Alzheimer's. So we'll have to figure out if they're included in some of this. They weren't named.
Okay.
Senator Cummings.
Yeah, we also have that whole problem with nursing homes because of the way we rate them. If an Alzheimer's patient acts out, they get marked down. So frequently Alzheimer's patients go to hospitals and the nursing homes are reluctant or won't take them back. And we've kind of set up that catch-22.
Right. And yes, I think Senator Hardy brought up wanting to hear from long-term care facilities, and that would include nursing homes. So we'll have Jill Olson come in and we can ask that very question. It goes beyond that. You know, if they're acting out and exhibiting some of the behavior that you were talking about, then they have to be equipped to handle those patients.
Yes.
You know,
and there's
so
only, I think, one nursing home in Vermont, maybe two that will do that. I had a friend who lived here, then they moved to Tennessee, but his wife had to drive an hour and a half to find a nursing home that would take him. And it's, you know, it's really difficult. I would really like to know. We used to have a respite program. I mean, I know someone now I know several people that are dealing with a spouse with Parkinson's.
right.
They need respite. They just need to be able to go away. You used to be able to actually go away for a weekend and have a respite care worker so that you could actually rest.
We don't have
Couple
that now.
days gave
Yeah.
that respite during the day so that you could work. And that whole structure, I think, is
We'll bring Dale
disintegrate.
in, I think.
Yeah.
We'll look at the whole respite question. I don't know that we can solve it all within this
No.
bill, but we certainly could have, I wrote down a note to myself that, and I think I mentioned it, to have the commission do an evaluation or an assessment of available respite care. It's not in there, I don't think. So
that
if we
would
could,
be good.
we might be able to add that, but we first need to hear from folks who are concerned about it. I know the disabilities community consistently concerned about having
Yes.
respite, and this is part of it. So, okay.
It makes
Very
the
good.
difference.
So I think we've got a little start on this one, and we'll put some testimony together so we can move forward.
You're making me restrain my Christmas tree decorating instincts. I could hang so much on this bill.
Yeah, I know, but it's worth asking the questions when we
Yeah.
hear from people, and
This
there
is
might be a little star that could go on top of this tree. So
Yeah. This is the forgotten disease. It
Yes.
hits old people. Sometimes it hits younger people, but
it's 50-year-olds,
yeah,
or
or younger. And
Oh,
we've had a few high profile cases, but at least until now, this is the generation that takes care of its own and doesn't ask for help. And frequently it's a real crisis
yeah.
when things come to light, and some of the situations are scary.
Yes. It's funny, and I don't want to prolong our discussion because we should move on to the other bills, but I was thinking about the generation that never talked about its healthcare problems
Oh,
And-
and
and the consequence of that on all of us.
Alzheimer's is, I think, considered in that area of mental disease.
Yes, that you are
And
ashamed. Yes.
You just don't talk about it.
Yeah.
Yeah.
Okay. Now we'll take a step away from Alzheimer's, and we'll move on to the other bills that we have for today. Senator Hooker has introduced, I think those are next. I have to get back into my iPad because it went dark on me. It's not behaving. And just FYI, my internet has told me it's not stable today. So if there's a problem, let me know. So we're down on to three bills, not 194, 195, and then 197. And Senator Hooker, excuse me, Senator Hooker, why don't you give us an introduction? Katie, do you think it probably best to do one at a time, or can we do both? What do you think about that?
I think it's up to you, whatever your preference is
Okay,
fine.
Senator Hooker, it's up to you, whatever your preference.
Well, I think they're kind of companion bills. They certainly have, common interests. And it's interesting that we were talking about respite. It's a good segue. This is 194 is a peer respite center bill. And it would, to define peer respites, they're voluntary short-term overnight programs that provide community-based, trauma-informed, and person-centered crisis support and prevention 24 hours a day in a home-like environment. Peer respites are staffed by individuals who with lived experience of recovery from mental health challenges, and that's where the connection comes in with S195. Peer respites are both an alternative to emergency department visits and inpatient psychiatric hospitalization, as well as step-down facilities from inpatient hospitalizations. We've certainly seen an increase in the need for the instances of mental health issues during the pandemic. And this problem of not having enough beds and not having enough step-down beds has been something that predates the pandemic. So these bills would look to helping to ameliorate the problem in a cost-effective way, because these peer respite centers are much less expensive than inpatient hospital and psychiatric beds. Let's see. So the bill would create 7 new geographically dispersed 2-bed peer respites located in throughout the state, and allow up to 14 days stay at any of these centers. They would be self-referral centers. They wouldn't need a prescription. These, again, would be staffed by people with lived experiences, and people who were having issues could go to them and stay for up to 2 weeks. Right now, we have 1 peer respite center in the state. It's Alyssum, and it's in Rochester. It has a 92% occupancy rate. It has a 5-day waiting period. It shows that there is a need for this type of facility to accommodate people who are experiencing mental health crises. I don't know if you want to go through the bill, have Katie go through the bill. No?
Sure. Would you like for her to go through the bill at this point?
Sure, go ahead, Katie.
Okay, why don't we do that? And then we'll come back to the next 2 bills. We'll do them individually.
Okay. Here is S-194. So as Senator Hooker said, this deals with the creation of peer-operated respite centers. There's sort of 2 parts to it. First is establishing or creating more peer respite centers, but there's also a pilot program that funds combining a community center with a peer operated respite center. So we'll look at that in the second half of the bill. This first section of the bill has findings. I'm happy to go through them. What is the committee's preference? I know in the interest of time, we often skip over findings. So
let's do that today, and we can read those independently. And I think Senator Hooker did mention some of the issues.
Okay. So Section 2 of the bill creates a new chapter in Title 18 specific to peer-operated respite centers. And then it starts off with the legislative intent of this new chapter that's being created. So it's the intent of the General Assembly that peer-operated respite centers established pursuant to the chapter achieve a reduction in wait times at emergency departments for patients seeking mental health care, an increase in community-based, recovery-oriented, and geographically diverse mental health resources, an increase in employment opportunities for individuals who have experienced 1 or more mental health conditions, and also better outcomes for Vermonters experiencing mental health conditions. And then we have a definition section. And while I do sometimes skip over definition section, I feel like it might be worth really understanding what a peer-operated respite center is and peer-run organization. Those are terms that are used throughout the bill. So a peer-operated respite center means a voluntary, short-term, overnight program that provides community-based, trauma-informed, and person-centered crisis support and prevention 24 hours a day in a home-like environment to individuals with mental conditions who are experiencing acute distress, anxiety, or emotional pain that, if left unaddressed, may lead to the need for inpatient hospital services. Then we have the term peer-run organization, and this means an entity organized and operated on a nonprofit basis that is controlled and operated by individuals with lived experience of one or more mental health conditions and provides support and advocacy for individuals currently experiencing mental health conditions. So then we move into the section on peer-operated respite centers. And this directs that annually the department, meaning the Department of Mental Health, is to distribute funds to one or more peer-run organizations in each of the following cities and regions to ensure that a peer-operated respite center is established and maintained in each location. Then we have the location list here: Bennington, Brattleboro, Burlington, Montpelier, Caledonia, Essex or Orleans counties, Rutland, and Windsor County. Subsection B directs the Department of Mental Health to adopt rules that specifically address the application process for peer-run organizations seeking to maintain and operate a peer-run respite center. So how do you apply for those funds that are available? The department's criteria for selecting successful applicants, operational standards for peer-operated respite centers, and also the annual reporting requirements for successful applicants. And subsection C is a reporting requirement from the department. So by January 1st of each year, the department is to submit a report to this committee and healthcare summarizing the annual activities of the peer-operated respite centers, including any challenges that may be addressed through legislative action. And then we have the pilot program that I mentioned. So in this coming fiscal year, the department is to establish a one-year pilot program by providing funds to a peer-run community center in both Burlington and Montpelier for the purpose of combining their efforts with those peer-operated respite centers operating in Burlington and Montpelier, pursuant to the language that we just reviewed. And then you'll see that we have language, let's see, in subdivision B1, that a peer-run community center that's participating in this pilot program shall provide quarterly reports to the department addressing how many individuals have been served under the pilot, the nature of services provided, the number of individuals likely diverted from emergency departments, and any other information that the department requests. And then by September of 2023, the department is to submit a report to the Appropriations Committees, House Healthcare, and this committee, detailing the total number of individuals served by the pilot program established in the section and any recommendations for expanding the program throughout the state. And then we repeat definitions that we've already been through. And the reason we're repeating them is because in the previous section, they were kind of set out in the green books. But in this section, you'll see this is session law. So this is separate from the green book. So that creates a need to make sure that we're using the same definition. And then we have appropriations for these programs. In fiscal year 23, 3.5 million is appropriated from the general fund to DMH for the purpose of distributing 500,000 to each of the peer-operated respite centers that were established in that first section. That was the list of towns and counties. And then in fiscal year 2023, 250,000 is appropriated from the general fund to DMH for distribution to the peer-run community centers that are participating in the pilot pursuant to the language we just looked at. And we have this taking effect on July 1, 2022.
So thank you, Katie. Specific questions on the language for Katie. The costs are in there. And I'm going to ask Senator Hooker a question, and then I'll go to you, Senator Hardy. I have a couple of questions, and Nolan's not here. So one of my questions is going to be about the availability of federal dollars to, I was going to say, gin this up, get this started. And I don't know the answer to that. Senator Hooker, do you have any?
I don't
sense
have
of
any
that?
indication of that, but certainly
Okay.
it's something that, we would ask JFO.
and then the $500,000 for each. It's a long list.
Seven
It's
centers.
a good thing that there's a pilot program in there. But so the 500,000 is also for the pilot. I should know that by now.
The pilot program is
250.
second part of this of
Right.
the bill. The 500,000 is for the centers, I believe.
Right. And then the second one is,
The two community centers that are already established that would work with the centers that would be established in order to provide a continuity of services and connections with other community services available to people who are at these respite centers.
so the community centers that we're talking about are,
In Burlington.
Yeah,
and in
do we know-
Montpelier. Yeah.
do we know the name of those
I
facilities?
do somewhere. I forgot.
No, we'll fill in the blank. Okay. All right.
And Senator Cummings probably knows someone in
In Washington County.
Montpelier, Washington County.
Well, I wondered why you chose Montpelier specifically rather than Barry would be the other larger city where real estate and rent tends to be less than Montpelier. I'm assuming we do have a day program here, I believe. So another way, one of the programs on your list.
So we'll get testimony on this.
Another way is
Go
a
ahead.
program that would be involved in the pilot program.
Okay.
Yeah.
And the other
And
thing,
the other
as
one
we
in-
get
in-
into this,
Mhm.
is now that these are going to be state authorized and funded programs, I want to make sure that they have adequate insurance in case something bad happens. And I don't know if there's any insurance requirements out there.
So
Right.
Senator, let's hold
Something
your,
like that.
write your thoughts down as we hear testimony. These are excellent questions. I'm just going to ask my one question, and then Senator Hardy had her hand up, and then keep a list. You can, I'm not stopping you from asking questions. I didn't want to move off where we were in the beginning on the appropriation. And I know that because I know Senator Hardy had her hand up. As we're going through the bill, Senator Hooker, the notion of having S-195 jumped into my head. And that is, if you're going to have peer support, they are specialized. They're going to need some training to ensure that they're doing the right thing. And that's just a question that doesn't need to be answered right now, but it's a comment. It's more of a comment.
And it will come into play when we discuss S-195.
Right. So the question is, cart before the horse. How do we put those two together?
Okay.
Senator Hardy. I know
Yeah.
can I just say something? I find it so difficult when we're not sitting around a table together. It's so much easier to go through a conversation like this, but we'll deal with it. Go ahead, Senator Hardy.
We're doing pretty well after almost 2 years, actually. I agree with Senator Cummings' comments about, insurance and accountability. We just had that accountability question with the parent-child centers, which have been around much, much, much longer. So that is certainly something, if we're going to start providing funding at this level. I totally am supportive of doing it, just wanting to make sure that we're doing that. I do have a concern though, because the pilot program seems to be simultaneous with creating all these centers. So it does seem like, don't you usually do a pilot and see how successful it is and then create the centers? So it's sort of a simultaneous thing, which doesn't quite make sense to me. Somebody already said cart before the horse, so it does seem like that. So what was the thinking on that, Senator?
Well, I think that the purpose is to establish these centers as quickly as possible because of the need, we've talked about, you know, of establishing more psychiatric beds. Frequently, people in these situations don't need to be in inpatient facilities, and these centers that have been established, you know, throughout the country have shown that they have much better outcomes for people who opt to go to those instead of going to the emergency room or to the hospitals or ending up in psychiatric care. So I think that the intent is to try to set these up as quickly as possible. I know that it looks like a heavy lift, but there are people in the community, the mental health communities, who have experience in these areas and feel that they have the bandwidth to set these up simultaneously.
So I just wonder then if we need the pilot program. It seems like if I hear you about wanting to set them up quickly because of the need. And if there are people sort of ready to go and they have a house and they have a place, then it just seems like the pilot program is either we're not waiting long enough to see what the results of the pilot program are, or we're trying to be so, we're trying to react to an urgent situation and therefore shouldn't take the time for the pilot. So I guess I just would like to hear more about that. And then, as you know, Senator Hooker, in the list of places where these are supported, you have left out Addison County altogether. And that is a concern of mine. One of the reasons I am not a co-sponsor of the bill, because I need to take care of my county. We are often assumed that because we lie between Burlington and Rutland, that we can just go to Burlington and Rutland, and that is a problem for a lot of people in Addison County getting that transportation. So if we are going to have a statewide network, we need to include my county. So,
well,
Oh boy, and I can hear Wyndham County saying the same thing because they're not
Wyndham
there.
County is Brattleboro.
Yeah.
Brattleboro.
Oh, it's got
Seven other counties
Brattleboro.
that
You're
are-
right.
It literally includes every place in the state except for Addison County. So
Oh,
that
well,
is
how
a
could
problem
anyone do that?
and not okay. So I am on this committee. I'm taking care of my county if we're doing this. And I think we should move forward with something as long as we work out the accountability and the pilot issue.
Okay, I have a question. I know, Katie, you want to weigh in on this. And then I'll talk after that. Go ahead, Katie.
I just wanted to help answer Senator Hardy's question, if that's okay.
Yeah.
So the first section of the bill is more about setting up the respite centers, establishing them, whereas the pilot is more about the partnership between a respite center and a community center. So I hear what you're saying, and I wasn't sure if that distinction was noted, that the pilot is that partnership between a community center and a respite center, not just establishing the respite center. And maybe you've already picked up on that, but I thought that might be helpful.
That's an important distinction. I think, but we also, that's great. Thank you, Katie. That's very helpful. And
That's why I asked the question about the community centers, because they are very distinct.
And the community centers are already established. So
yes,
it's not as if you're starting two new projects.
Yeah, but that does raise a question about other community centers that may be well established. And so we're going to have to ask folks who come in their testimony to comment on this. Senator Cummings.
Yeah. 2 years ago, 3, a long time ago, before COVID, BC.
Oh, that's great.
Yeah, when we had, because it's now BCE for before Christian era.
Yes, I know.
We set up peer emergency beds when we had mental health patients backing up in the emergency room, several places in the state. I know Washington County, there were emergency beds that were peer supported, and that kind of fell by the wayside with COVID, I think. But we might want to check with our local mental health agencies to find out the status, this, because this is a similar thing. And
Yeah, this is, and we can talk with the Washington County mental health folks have
Yeah.
been very helpful. They usually have a kind of the finger on the pulse for the rest of the state. So we'll do that. And I have kind of a related issue, which is defining the patient who's going to be going to the respite facility. You know, I can think of someone who has depression and may feel compelled from time to time to do harm to his or herself, to oneself. And that person might benefit from having some peer support. I also think of someone who is in an acute stage who probably needs to go to a more acute facility for a period of time. They wouldn't necessarily, or they could be referred out to the respite. So I think it's important that we understand who is going to be going to these facilities. I'm not sure that it will always take the place of the emergency room or the hospital, but we are trying to take the pressure off. So somehow we're going to have to sort that out just a little bit. And that's testimony, and I know we'll get that, but it's an important consideration. And that goes along then with the training that we will see next coming up. So,
And the
Senator
bill
Hardy?
does,
Yeah, go ahead, Senator Hooker.
no, I was just going to say that the bill does say that people would be self-referred. So
Yes, yeah.
that's, and
That-
again, we'll have to talk about what does that mean? And
What does that mean? Because, we've got mothers and fathers bringing children in, so there are some issues about that self-referral. And then there are families who would like to refer adults, but they can't. And I know I knew someone who you all knew probably, but I knew her very well from my district, who was a terrific lawyer. And if she'd had some peer support, may still be here with us. So it's a very interesting issue. Senator Hardy.
I just wanted to note for fairness purposes that the other county that's not listed at all is Franklin County. So
Test.
we should at least add Franklin and Addison. Every other part, I believe, is in there in some way or another, either named by a city or a county.
And
We'll
I'm
have
sure that there would be no objection to adding centers.
Well, it just adds money, and we're the money committee, right? We can add all this money.
We have Senator Hardy on the money committee, so
we've got a heavy lift.
Senator Cummings and I are on the wrong money committee. We have to raise the money, not spend the money.
But you're going to evaluate the use of ARPA funds for us, and what are the guidelines?
I would love to be on that committee.
All right. Other questions for Katie and comments? All right. Senator Hooker, you are on the hook.
For S-195, which is, I would see it as a companion bill to the Centers bill, because it is one that provides, it's a program, a certification program for providing evidence that an individual has met the qualifications to provide peer support to individuals with mental health and substance use challenges, or family-to-family peer support to parents and caregivers of children and youth receiving services for mental health, substance use, and related service systems. 48 states and the District of Columbia have such programs, have adopted this peer support certification program, and Vermont is, well, obviously one of 2 states that has not. The other, I believe, is South Dakota. This would allow not just the peer support that has been proven to be helpful to people with mental health conditions, but also allow for these services to be paid by Medicaid. Medicaid and Medicare centers have suggested, encourage this type of program and certification, and certainly here in Vermont, there's been support for this kind of service to people with mental health issues. Again, helping to eliminate or ameliorate the backups in hospitals and emergency rooms. These people would be able, these service providers would be able to work with emergency room facilities, work with law enforcement, work with recovery centers to help people who need this help. And it's been proven to have better results, or at least proven to have good results with people who have taken advantage of this kind of peer-to-peer counseling. So I think one of the big issues here is, where we can get money to pay for these. And because people would have be certified, they would be covered under the Medicaid.
Senator Hooker, and maybe Katie can answer this question. What is the title for these folks under Medicaid? Is it a peer support, a peer-to-peer, or is it recovery coach? Because I know.
No, there's a difference between the peer counselors or peer support people and the recovery coaches.
Good, because that's going to become an issue going forward.
Yeah. And they would, let's see, they're called peer support specialists.
Okay.
And we can go through the bill. Katie has those definitions in the bill.
All right.
And we have, this would establish the parameters for peer support specialists, what they would have to do. The state would come up with the program for them, and they would have to comply. They would have to abide by the program.
So, yeah, and just as the bills were put together, what was your thinking about? I know I met with folks on this as well. You and I have talked about that, but what was the thinking about, initiating the centers before the whole educational type program is available? So that's something we might want to think about.
Yeah, well, we can look at the implementation dates on the two bills.
Katie can help us with that.
Yeah,
She's got it memorized perfectly.
Yeah, there you go.
It's like, right. You.
No pressure, Katie.
Go ahead, Katie. You've got all the answers.
It's just the way I am. I can't apologize for it. Okay. Katie McClend.
Okay. So we're on S-195, which is the Peer Support Specialist Certification Bill. It starts off with some findings. So as we did previously, I'll just skip over these for now. And then we're creating a new chapter in Title 18. And it starts off with the purpose section. It is the intent of the General Assembly that the Peer Support Specialist Certification Program that's established in the chapter support the ongoing provision of services by certified peer support specialists for individuals experiencing a mental condition or substance use disorder or both. Support coaching, skill building, and fostering social connections among individuals experiencing a mental health condition or substance use disorder or both. Provide one part in a continuum of services in conjunction with other community mental health and recovery services. Collaborate with others providing care or support to an individual experiencing a mental health condition or substance use disorder or both. Assist individuals experiencing a mental condition or substance use disorder or both in developing coping mechanism or problem-solving skills. Promote skill building for individuals with regard to socialization, recovery, self-sufficiency, self-advocacy, development of natural supports, and maintenance of skills learned in other support services, and encourage employment of peer support specialists. So then we move into the definition section, and the term certification means the activities of the certifying body related to verification that an individual has met the requirements under the chapter, and that the individual may provide mental health and substance use disorder treatment under the chapter. Certified means all federal and state requirements have been satisfied by the individual who's seeking the designation, including completion of curriculum and training requirements, testing, and agreement to uphold and abide by the Code of Ethics. The Code of Ethics is a standard that peer support specialists are required to adhere to. Collaborative documentation. This means a model in which peer support specialists and recipients of peer support services collaborate in periodically creating intake and assessment summaries, service plans, progress notes, or tallies of services rendered, or any combination. So this type of documentation may be completed weekly, monthly, weekly or monthly intervals rather than at each encounter. We use the term core competencies in this bill to mean foundational and essential knowledge, skills, and abilities required for peer specialists. Peer run, I think we sort of covered that in the last bill. And then peer support is an approach to relationships that recognizes each individual as the expert of their own experience, fosters connection through shared or similar experiences, and centers mutuality and mutual support, preserves autonomy, and creates an opportunity for meaningful connections and exploring possibilities. This defines the term peer support specialist to mean an individual who's at least 18 years of age, who self-identifies as having a lived experience with the process of recovery from a mental health condition or substance use disorder or both, including the parent or family member of an individual who has had a lived experience and who has been granted certification pursuant to this chapter. And then recovery is the process of change through which individuals improve their health and wellness, live in a self-directed life, strive to reach their full potential. The process of change honors the different routes to recovery based on the individual. And then we have language kind of creating this program around a peer support specialist certification. So just to kind of let you know how this section is structured, it's divided into A, B, and C, 3 subsections, and each one asks the Agency of Human Services to contract with a peer-run entity for a different purpose. So in subsection A, you'll see it's for the program development of this certification program. In subsection B, sorry, just scroll down quickly, screening and training of individuals, and then subsection C is the certification of individuals. So we'll go through each of those in a little bit more detail. So first, the program development. This directs the agency to contract with a peer-run entity to develop a statewide certification program for peer support specialists in accordance with guidance issued by the CMS State Director Medicaid letter. And this is something we could put on the website if you're interested in posting that.
Yes, please.
Okay, let me make a note to myself right now. This entity under contract shall define the range of responsibilities, practice guidelines, and supervision standards for peer support specialists using leading practice materials and opinions of peer experts in the field. The entity shall determine the curriculum and core competencies required for certification, including curriculum that may be offered in areas of specialization, such as Veterans Affairs, gender identity, sexual orientation, and any other area of specialization that's recognized by the certifying body. The core competencies curriculum shall include at a minimum training on the following. So peer support values and orientation, including authentic and mutual relationships, lived experience, the concepts of resilience, recovery, and wellness, self-determination, trauma-informed practice, human rights-based approach and advocacy, cultural competence, group facilitation skills, including communication, dialogue, and active listening, self-awareness and self-care, conflict resolution, professional boundaries and ethics, collaborative documentation, skills and standards, and confidentiality. Continuing with the responsibilities of this entity setting up the program, establishing a code of ethics, determining the process and continuing education requirements for biennial certification renewal, determining the process for investigating complaints and taking corrective action, which might include suspension or revocation of the certification, and determining a process for an individual employed as a peer support specialist on or after December 31st, 2021 to obtain certification pursuant to the chapter, including at a minimum passing certification examination specifically created for this purpose.
Oh, wait, can I ask a question about that date in there?
Mhm.
Does that mean that anyone who's acting as a peer support specialist would be validated if they've been doing this before December 31st, 2021? Trying to figure out why that date is in there.
Sure, determining a process for an individual who's employed as of December 31st of the previous year to obtain a certification pursuant to this chapter. Passing certification.
Yeah.
I'm not sure if it's meant to keep people in who already had this, or
Yeah.
say that in addition, you have, in addition to your prior experience, you need to pass the certification exam.
We'll have to sort that out.
I'll have to look at it more closely with the lead-in language.
Yeah, okay. No, not a problem.
Yeah.
Senator Hooker, you wanted to
I
comment?
was just going to say, I think that it's intended to allow the people who are already doing this work to have access, maybe in a more expedited way. I'm not sure, but we could, certainly. check.
Yeah, okay. Kind of makes sense.
Okay, we're still in the program development subsection, and now we're in this subdivision 2. In developing this certification program, the entity that's under contract to do this work is to seek feedback and recommendations from mental health peer-run and family organizations, hospitals, and mental health and substance use disorder treatment providers and organizations by convening not fewer than 4 stakeholder meetings. So that's the first piece. That's the entity that's creating the certification program. And now
And
we're
the-
moving on to subsection B, which is the screening and training.
So
So
the entity itself is someone selected to do this. I left it back in the words, so
Yep. So
the
it's the,
selected organization.
in each of these subsections, it's the Agency of Human Services that is selecting and issuing a contract with different peer-run entities to do these different sets of work.
And there's no requirement that the entity be familiar with the state of Vermont or anything like that, just an entity that does this.
I can't recollect. I don't.
Okay, well, we'll figure it out.
We can go back to the definition of peer-run entity to refresh my memory of how we're defining that.
No, keep going and I'll
going? Okay.
I'll scoot back and look at it. Yeah,
Okay.
I've got it. No, it just peer run, an entity, program, or service that's controlled and operated by individuals with lived experience of the mental health system and a mental health condition or substance use disorder. So it's a fairly it's broad and it's narrow at the same time. Okay, thank you. I don't need any more than that right now.
Okay. So next, the agency is to contract with a peer-run entity to screen and train prospective peer support specialists consistent with the curriculum and core competencies that were developed under the previous subsection. And then third is the certification piece. The agency is to contract with a peer-run entity to serve as the certifying entity for mental health peer support specialists. And this,
Okay. Sorry, I didn't
That's
mean
okay.
I didn't mean to say it out loud. My little brain was thinking, sorry. Go
That's
ahead.
okay. So this entity has two responsibilities. First, determining whether an applicant has met the requirements for certification through the administration of an exam. And secondly, adhering to the processes for certification, recertification, certification, revocation, and appeals that have all been established in subsection A. And then in subsection D, we have an exemption. Individuals who are providing peer support services as employees or volunteers of a peer-run organization are not required to obtain peer support specialist certification.
Okay, I'm having a little deja vu here with parent-child centers and thinking that we're giving a lot of authority to an entity. So something as we go through and hear from folks to ask questions about and consider.
Okay. The next section deals with how a person would go about getting this certification. So an applicant must be at least 18 years of age, be self-identified as having firsthand experience with the process of recovery from mental illness or substance use disorder treatment, or be a family member of such an individual, be willing to share personal experiences, and agree in writing to the code of ethics that was developed according to the previous section that we just looked at. A person would also need to successfully complete the curriculum and training requirements for a peer support specialist. And they would need to pass a certification exam that's approved by the certifying body. And then to maintain your certification, after you've already initially gotten your certification, you want to maintain it. You have to adhere to the code of ethics and sign on a biennial basis an affirmation form to that effect, and also complete any required continuing education, training, and recertification requirements that are developed by the certifying body. In terms of a fee schedule to operate this program, this language just says that any fees that might be required to administrate this certification program shall be requested pursuant to the process that's already set forth in statute. This means going through the fee bill process. And then the next section asks for an amendment, a state plan amendment for the Medicaid state plan. So this directs AHS to seek approval, directs AHS to seek approval from CMS to amend Vermont's Medicaid state plan to include a certified peer support specialist as a provider type, to include a peer support specialist services as a Medicaid covered service, and to allow beneficiaries to self-refer for peer support specialist services, to allow for collaborative documentation of peer support specialist services, and to allow reimbursement for peer support specialist services for a range of healthcare common procedure coding systems codes. And then the bill goes on to list what those codes are. It's a little bit unusual to list out the specific codes in statute. Usually there would be something a little bit more general, but the committee could explore this approach also.
We'll have to hear from Diva.
And then we have two definitions that you've already seen. And the reason, again, it's the same reason you saw before. I don't remember which bill it was at this point. But because the previous section was in the green books, and we had the definitions set out there, and this other section is in session law, we're repeating the definitions that we need so that it applies to this piece of session law. And then we have language in section 4, Medicaid reimbursement for peer support specialists. We have a definition. This is a different title. This is all the language we had in the chapter creating the certification program was in Title 18. Now we're in Title 33, where Medicaid reimbursement lives. And we're repeating a definition just because it's in a different title. So we need to repeat that definition. And then we direct that that DIVA shall reimburse peer support specialists in accordance with Vermont's Medicaid state plan. And you'll see that we have kind of a staggered effective date because this can't take effect until the amendment to the Medicaid state plan happens. So you'll see that when we get to the effective date section. The appropriation for this in fiscal year 2023 is $525,000 to HS, appropriate to HS from the general fund for development of the certification program. And then it says the agencies shall seek to maximize federal financial participation in funding administrative costs. And then effective dates, as I said, the bill takes effect July 1, 2022, except the section we just looked at, the section 4, the Medicaid reimbursement, shall take effect once there has been approval of the Medicaid state plan in section 3 by CMS.
Okay, there's a lot here. In some ways you could say, wow, this is a workforce development bill. We're increasing substance use disorder and mental health services of workers. So it's one way of looking at it, but there are a lot of details in here that we need to consider. I'll get to you. And then, yeah, so we're going to have to hear from the folks who proposed this in the first place and DEVA, and then the money that's coming in is going out to an entity, and what is the grant process there? We have a lot of things to consider, but Senator Hooker, you have a job to do in terms of providing us with some of the folks who will come in and testify on both of these bills.
And just to your point about workforce development, this would give people who are characteristically some of the hardest to place in the workforce because of their previous experiences. It would give them a way to, an opportunity to rise up and to continue to work and to help others who are in similar situations, but also to kind of climb a ladder of credentials that would make them, elevate their purpose, really.
Thank you. Yeah, we'll have to look at that. I have one question for you, Katie, and then I know Senator Hardy and Senator Cummings each have questions, but there are two separate statutes in here. There's a separate chapter here for this one, and the previous bill was also a separate chapter. So this one has a separate chapter for our peer support specialists for mental health and substance use disorder. So it doesn't restrict their work to the centers that we were here, the respite centers. This would allow for them to work in a recovery center or work in a hospital. They could work anywhere where their sort of understanding and counseling support was needed. Is that accurate?
That's correct. That's not where I thought you were going with this question. I thought you were going to ask if you could combine the chapters. But
well, I'll go there next.
There's nothing that in the certification program bill, there's nothing that limits where somebody who's certified could work. It wouldn't be limited just to the peer respite centers from the previous bill. And
then similarly, then the next question I have is that the folks who are currently working as peer support specialists, if they are exempt from the certification process, then can they move and work other places with the understanding that they're certified?
Well,
I think that's something that the committee needs to think a little bit more about how that piece would work. We could craft language any way you'd like it to say,
okay.
That a person is deemed certified and,
just trying to figure out, that what it means to have those two separate chapters. Do we combine them? What does it mean for the folks who are currently working, and where else would they be employable, and what certification would they have if they're exempt? So all of those questions that we'll have to kind of look at. Okay, sometimes the hamster runs too fast. Okay. Senator Hardy and then Senator Cummings.
Thank you. So Katie, the section where you're listing all of the codes, the billing codes, is that statute or session law?
That's session law.
It's
Session.
page 10. It's session.
Session
It
law.
is session law. Okay. And then I believe Senator Lyons, you said something about providing this funding to entities, but it doesn't seem like it would be. The funding is provided to AHS to develop this certification program.
But the certification goes through an entity. Am I inaccurate in that, Katie? I'm trying to.
Yeah, so AHS gets the initial appropriation, and then what the section 1 is setting up, is it section 1 or section 2 is setting up, is that AHS would almost be issuing grants, like selecting different entities to do this work using the money that was appropriated for that purpose.
To do the work of certifying people?
Well, A,
Setting
B,
up.
that those tasks in A, B, and C. So one task would be the setting up the program, the certification program. A second task would be screening and training potential candidates. And the third task would be certifying the candidates. So it's 3 different entities in a contractual relationship with AHS to do those 3 different jobs.
And is there another that you know of program that works like a employment certification program or professional certification program that works like this?
Not that I'm familiar with, but maybe Damien could probably give you more information than I could.
Okay. I guess I would really like to hear from Lauren Hibbert in OPR about, I think we need to balance the workforce needs and the safety of individuals if they're getting counseling from someone, and making sure that the certification process is sort of consistent with other certification processes that we have for employees. It may very well be, and I think that we need to balance this really crucial need in making sure we get these people out and certified, with making sure that we're following sort of a tight enough procedure to ensure public safety.
One of the ways to do this would be to give it to an institution of higher education, or a technical college or school. So there are different ways of looking at how to build this and then oversee it. So if I think your suggestion of having Lauren Hibbert in is a very good one. So we'll do that. And we'll have to listen to the folks who come in who are supporting the bill and see what their thinking is. Yes, Senator Hooker.
Thank you. Can I just say that people are already doing this work?
Yes, we get it.
The certification is to help us get Medicaid funding, to make sure that, we can support this work through the funding that's available through the federal government and the state.
Right.
But when we're using public funding for a program and Medicaid funding, that's when we want to especially make sure that.
Yeah, no,
the
I agree.
certification
I
is-
agree
yeah.
that we need to talk about the licensing as well.
And
Yeah, I
they-
don't think, go
they
ahead.
already license and certify mental health providers. So I think there may be, already a sort of
Track that we
model
can use.
set up that we might be able to piggyback on.
Okay.
We'll find out. Senator Cummings.
Again, my caution flag is going up. We're talking about people that are very vulnerable. And we are talking about having people who may not be vulnerable at the moment, but have been vulnerable. And if we're saying, well, they can't get employment other places, then we're talking about somebody providing services to a vulnerable person who is or may be vulnerable. And we're now going to formalize this as a state program. And these are the kinds of things where they are great, but if they take off without the proper guardrails, seems to be the new word, and something goes wrong, and the odds are something will go wrong. They go wrong, in hospitals, something, and it could kill the program. And I'd like to make sure, I think I'd like to start, with some pilots, with some formalizing, working with some of these programs that are there now and working through them, and then expanding as we develop the model. Because it's not just who's doing the peer counseling, it's who determines who gets into this program. We have a lot of we have records in the past of homeless people with mental health issues showing up in emergency rooms on very cold nights. And this would be another warm place to show up on very warm, and who screens and who triages and who decides who gets in, or are we just saying anybody that shows up gets in? Who's doing the screening for who?
So you're
gets in?
asking all some very good questions, and which is why I asked the question about who's the patient earlier.
Yeah.
And how do we determine that? So we'll take testimony. I think it feels like there's a lot here. It's huge. And there are some people who have been working in this area who may feel that we're behind in putting all of this forward. But at the same time, there are huge questions here that we need to understand. And I agree with you, Senator Cummings. We don't want to put something in place that is going to fail. So
Or hurt someone.
we'll take testimony. And as you're thinking through, Senator Hooker, you have names that you can forward along. I know you've already done that, and I greatly appreciate it. And then we're also we want to hear from OPR, from DIVA, and from who else? I've written some down, and we'll put those together. Vaz, yes, yep. We have a list.
Yep, we have a list.
Okay, so
But
send your
certainly-
list to me and then copy Aaron, and then when we put the testimony together, we'll try to make sure we cover everything that everyone's interested in.
And some
Certainly a big-
participants in existing programs.
Yes.
Yes, yeah, we'll get,
And
we
you know,
have that.
one of the
but-
things you asked about, who is screening them, and we could talk to Alyssum, the only center that we have in the state, but there are
Yes.
also centers, from other states and experiences from other states that we might want to draw from.
Okay,
Thanks.
let's get some of that. That's very helpful. Whether it's written information or telephone Zoom testimony is so much more convenient for out-of-state folks. We may be able to get some. Okay, good. Thank you. Anything else on 197? No, that's not 197. That's 195. And okay. So what I'd like to do is to go through 197 briefly, and then hopefully we'll be able to finish a little bit earlier. I do apologize for not giving us a break today, but I think we may as well just continue on and then try to finish a little bit early. So Katie, the next bill is 197, which is something I introduced, and I'll tell you why I introduced it, and then what is happening outside there. I was contacted by someone from the Northeast Kingdom which is not in my district, but I responded anyway, because I think this is such an important issue, who said that an EMT could not go into help someone in a mental health crisis if the EMT was alone, thinking that the EMT thought that they would have to have a public safety person with them. And as a result, I think it's as a result of a lot of the conversation and publicity that we had last year, the year before, regarding embedding mental health folks in the barracks, the police barracks. So I said there are no laws and guidelines about that. Tried to sort that out, and I can't remember, Katie, whether I contacted you about that or not. But I think I went through everything myself, and then said we don't have guidelines that limit you in your EMT response. But the issue was that the Department of Public Safety had issued guidelines, but not about that. And the Department of Public Safety agreed with me that they weren't restricting that response, that emergency response. Then I started thinking about all the things that are going on at the municipal level. We have the mobile crisis unit that's in the Rutland area. And I know the governor's proposed more of that. In my district, we have social workers who work with the municipality and couple their work with public safety, but now work independently of public safety. I have a town that came together, putting together local responses to mental health crises in town. And we have the Vision program. We have other programs that are distributed across the state.
Mhm.
And we have mental health counselors embedded with public safety. And as I have been concerned right along, who's in charge of determining some of the criteria and conditions for the mental health response. And it's my sense that Department of Mental Health should have something to say about this. And I don't know whether the MOU between DMH and DPS was ever finalized. So I put the bill together just to get a conversation going and think about how a more coordination of guidelines and information would be helpful to folks as they're developing programs. I'm not trying to step in to change programs at the local level. I think they're all really doing such a good amount of work. I think of the work that's going on in Burlington, South Burlington, Rutland, Montpelier, and other places. St. Johnsbury is starting to get involved. So then I talked with Morning Fox, who you may know used to be Deputy Commissioner of Department of Mental Health, who is now working for the Department of Public Service. And he's also concerned about the same issue. It may have been driven as a result of my inquiry of Department of Public Service about the disconnect between guidelines. Did you want to say something,
No,
Senator?
it's public safety. Public service is broadband.
Thank you.
You're in my territory.
We don't need the public service in this. 911.
Not yet.
Public safety. Thank you, Senator. So anyway, so he and I chatted a bit, and he was very much supportive of bringing a group together to look at how to coordinate some of these issues. So I don't, none of us enjoys putting together a task force or a working group. But right now, mental health for me is on the front burner. And I think that we probably should have this conversation and determine what it is that we can do that will help bring folks together and ensure that we don't have people going off in separate directions. I think it's very similar to the questions that we were asking about who's the patient and who are the people who are serving those patients, and what coordination is there and what's the leadership on that. So I'm thinking that we'll bring that if we could go through the bill briefly, and then we can talk about who we want to bring in. Obviously, there's some people who are front and center on this.
Just did our bill on the mental health counselors did that make it through for setting up our A to Z group
Oh, you mean on the wellness?
on the wellness? Yeah.
Yes,
Has that
yes.
made it through the legislature?
Yes.
Okay.
20, how many? Alphabet.
We did the whole thing.
Was it an out? Well, how much was it, Katie?
Maybe it
I
was
thought we
too
went
much.
past the alphabet.
Yeah, I thought so too.
Yeah,
Okay.
I mean, it would be interesting as we work through this, because that's the other side is,
The problems.
is
Yeah.
what have they met? I mean, what's happening to help those folks that we're sending out deal
That's
with.
yeah, I do. I think that that's an analog. It's very ancillary to what we're talking about. We certainly can pick up on that. I think for me, it's how can we coordinate this stuff and make best practices available to other municipalities, and then move it forward a little bit. And I will just say right out front, and I told Morning Fox this, that I have a great deal of confidence in the work that he's doing in the Department of Public Safety, but someday he may not be there, and we may not have someone with his mental health experience and background. So what can we do to ensure that going forward, there's some direction, statewide direction? And for me, that lands in the responsibility for the Department of Mental Health. But so anyway. Oh, Katie, why don't you just walk us through this long bill?
Sure. Our last one of today.
Yes.
Okay. S197, this creates a coordinated mental health crisis response working group. So subsection A is just creating this working group, and it specifies that it's for the purpose of developing and articulating a predictable and coordinated system of response to mental health crises among law enforcement, emergency medical service providers, emergency departments, healthcare providers, and community mental health service providers. And then it goes on to list the members of the committee. So we have the Commissioner of Mental Health or designee, who shall serve as chair, the Commissioner of DPS or designee, Director of the Office of Emergency Medical Services, the Chief Superior Judge, a representative of hospital emergency departments appointed by VOS, a representative of the DAs and SSAs appointed by Vermont Care Partners, an individual who has previously experienced a mental health crisis appointed by Vermont Psychiatric Survivors, and a family member of an individual who has previously experienced a mental health crisis appointed by the Vermont chapter of NAMI. And then we go on to list the duties of this working group. The working group is to explore the existing response to mental health crises in Vermont and develop a predictable, coordinated response plan across public safety and healthcare sectors. And the working group is to determine a process for educating individuals who respond to mental health crises about the plan developed pursuant to this subsection, communicating with the public regarding the best way to access mental health crises services, and in subdivision 3, ensuring individuals experiencing a mental health crisis are connected to therapeutic services in a safe environment once the initial response has concluded. In terms of assistance, the working group has the administrative, technical, and legal assistance of DMH. And the reporting requirement is that the working group is to submit a report on December 1st of this year to this committee and House Healthcare with recommendations and findings. And then the language governing the meetings, the Commissioner of Mental Health or designee is to call the first meeting by August 1st of this year. A majority of the membership constitutes a quorum, and the working group ceases to exist on December 1 after the report has been submitted. In terms of compensation, members of the working group shall be entitled to per diem compensation and reimbursement for not more than 4 meetings, and these payments are to come from the money appropriated to DMH. And then it takes effect on July 1, 2022.
Okay. And there probably the membership of that's going to change radically. I know that VLCT might be important,
Yeah.
and I think Vermont Family Network. So, I mean, anyway, that's what that little bill is, and we'll see what the testimony brings us.
Yeah.
Senator Hardy.
Yeah, I appreciate the problem this is trying to address. I mean, I think this is true in a lot of our
Trying.
communities. It certainly came up in my community as well. I have to say that I get just like a little bored with like more working groups trying to solve problems that it feels like we should be able to solve without a working group. But if there's another methodology for doing this, I would love to find it.
Well,
And
you know, there
we just
is,
end up having just a list of people, and it just seems silly. But the one thing just on this, the sort of technical things, Katie, the per diem, it should be clear that it's not for people who are, you know,
Being paid.
participating as part of their job, basically. Like we
Mhm.
shouldn't be giving the DMA secretaries and those people the per diems. Maybe
Yeah,
that's implied, but
this is our standard language that we use
it?
across all, and I'm pretty sure that if I were to check the cross-reference, which I'm happy to do, it would specify
Oh.
who can take advantage of that.
It might be in the cross-reference, okay. And then just making sure that they are, all of the like big wigs have designees, like this chief superior judge doesn't seem to have one. And I think one of the big reasons that this was an issue in communities this year is staffing was a problem. So like the designated agencies were not able to respond in a way they normally would because they just didn't have people to send out and help. That was true in my community. And so I don't know how necessarily we deal with that. I mean, maybe Senator Hooker's bill will deal with that, but a lot of it is staffing issues that's causing the problem.
Senator Cummings.
Yeah. I think we definitely need more local representation. We've got all the state department heads, but the service is delivered on the ground. And one thing that didn't get mentioned is scope of practice. I worked with a nurse who was also an EMT. Her scope of practice was much broader as an EMT than when she was working as a nurse. So when she's on the ambulance, she could do some things, but when she was a nurse at an adult day, she couldn't do some of those things. So that may get in there. And yeah, I think some of the most horrifying testimony I ever heard were from parents of autistic children, usually sons, who have trouble winding down after the day and tend to just escalate physically, and they reach a certain size in which they become dangerous to family members. No intent, it's the nature of the condition. And you call frequently, you can't get a mental health worker. These kids are frequently handcuffed or strapped down on a stretcher and hauled out of the house for everyone's safety. But it's horrifying.
Right.
And though I think that's the kind of thing that makes it real. How do we deal with this? And it falls to the local EMT who has no idea because they've never been called to do this before. So part of it may be training.
Yes, you know, you're absolutely right. And you're talking about some of the issues that the Vermont Family Network cares about. And I know that they've been engaged with the Department of Public Safety on this. And I know that Morning Fox is very interested in pulling the local folks together. And I couldn't agree with you more, so we're trying to get at it. This is the bill that I've put in is really meant to begin this process and conversation. But I don't think we can leave it just to happen organically.
No.
We need to have something that helps coordinate this stuff. And you'll notice that the group ends its work after 1 year. So it's not an ongoing something. It's just, let's think about how to do this better. Let's bring people together. Let's see where we are. And then if there are recommendations to be made at different levels, make those recommendations. So that's all it is. And I agree with you. It's got to be boots on the ground. Totally.
Mhm.
And it may help. One of the things that I asked Senator Hooker about was the difference between recovery coach and a peer support specialist. And right now there is a lot of discussion about recovery coaches being the preferred term, but they're obviously two different things. So this might open up a conversation with the folks who actually are out there working. And I know that Mad Freedom is wants to work on this as well. So we'll see what we can see. All right. Any questions? Comments? I know we don't like working groups, but sometimes it allows for people to express themselves and helps everyone move forward. People get stuck in their little silos, so we want to keep the communication going.
We just
Okay.
have to make sure the right people are on it. I agree
Yeah.
that we need more local people. The secretaries don't need to be on these kinds of things
No.
all the time. And it's just silly that we put them on there all the time. And there are some problems that it makes it take longer if we have a working group than just, hey.
Well,
solve this problem.
we'll talk about that. And so the commissioners are important for two reasons. One, we want, for me, having Commissioner of Mental Health engaged is really important. My question is, do we need the Department of Health involved in this? I know we've got NAMI, we've got DAs, we have SSAs, we have Vermont Family Network, VLCT, Mad Freedom. There are a bunch. There's a whole bunch. So
Who's Mad Freedom?
I think is that Wilda's group? No, yeah, that's what I thought.
Okay.
It's a mental health organization.
Yes, it is.
Yes. Oh, thank you, Aaron. Okay.
Strange.
All right. Anything else? Your thoughts on who should be in the
There
working
is some local head or state head of EMTs. But you should get some representation from the local the local ambulance services and the local police departments.
Yeah.
Because that's when things get bad, that's where they end up. And I think we should hear from the locals. It's
I
not
couldn't
the
agree more.
stadies first, it's the
Yeah.
locals.
I know that in Richmond, in my district, Dr. Richard Bernstein was a volunteer on the fire department. He's also a physician, and he brought the whole town together. He, along with the police chief, brought the whole town together on trying to solve mental health and substance use disorders when there were some burglaries taking place at local businesses. And so they've created
One
this
way you
whole-
know you have a drug issue.
Yeah. So anyway, we've got a lot to go through on this one.
Yeah.
Okay. Committee, thank you for working through. Keep your thinking caps on. We come back tomorrow to the task force report on affordable, accessible healthcare. If you have a minute or three, please go through the slide deck and or the report. That would be helpful.